Okay, so good morning, everyone.
This meeting is being recorded.
Good morning, everyone. My name is Anna, and I'm going to present about cerebral venous thrombosis. So we're going to start with a case. We have a 19-year-old previously healthy woman. She has no history of headaches. Her only medication is an oral contraceptive pill with estrogen. She has a family history of thromboembolism in her uncle. He was diagnosed with antithrombin 3 deficiency after having multiple pulmonary emboli. And she's presenting for this past week with progressive holocephalic headaches. They have become intractable. She tried over-the-counter medication, but it didn't help. And she's also having nausea, increased lethargy, dysarthria, and left hand tremor. All these symptoms prompted her to go to the emergency department. Her physical examination, the vital signs were normal, and she also had a normal BMI. She was somnolent, but easily arousable to voice. She was oriented when awake. She had mild anisocoria. Her right pupil was slightly smaller than the left pupil. She had no papilledema, and her neurologic examination was generally non-focal, and she had no meningeal signs. So we have here this 19-year-old woman with combined oral contraceptive use and family history of thromboembolism that developed subacute progressive headaches and lethargy. So what is the differential diagnosis for this patient? So we're going to talk about the diseases, of course, with increased intracranial pressure. So we have cerebral venous sinus thrombosis, obviously, which is the theme of the presentation, hydrocephalus, intracranial hemorrhage, most specifically subarachnoid hemorrhage and intraventricular hemorrhage, aseptic meningitis, reversible cerebral vasoconstriction, and posterior reversible encephalopathy known as PRES. So what is the clinical presentation in the venous vascular territories involved in CVT? So CVT is mainly a disease of the young, most specifically young women. The female to male ratio is about 3:1, and the mean age of presentation is 33 years old. Less than 10% of patients over the age of 65 will develop thrombosis, and of these patients, when they do have the presentation, it's going to be mainly delirium and encephalopathy. They are more common than headache. And speaking of headache, it is the most common presenting symptom. So it's present in roughly 87% of the population that presents with CVT. But isolated headache, it's not that common. It usually comes with other signs and symptoms of increased intracranial pressure. So nausea, vomiting, visual field defects, seizures, focal neurologic deficits, altered consciousness, and cranial nerve palsies. So CVT can be thought of as 4 different entities at presentation. So you can have headache with or without intracranial hypertension, which is the most common presentation. We can have a focal syndrome with neurologic deficits and sometimes seizures. We can have diffuse encephalopathy or coma, and we can have cranial neuropathies with painful ophthalmoplegia. So let's review a little bit about the anatomy. So let's start first with this one, which is the superior sagittal sinus. It runs from the frontal lobe all the way into the occipital protuberance. Then a little bit below it, we have the inferior sagittal sinus that drains into the straight sinus. The straight sinus and the superior sagittal sinus meet here at the confluence of sinuses. And also draining into the confluence of sinuses, we have the occipital sinus. And from here, the blood flows to the transverse sinus, also seen here. They run along the occipital bone. And next we have the sigmoid sinus, which is also presented here in this side. And they go down to the internal jugular veins. Additionally, we have the cavernous sinus here and here on both sides of the sella turcica, can also be seen here. And they drain into the superior and inferior petrosal sinus, which then go ahead to drain to the internal jugular veins. The most common locations of the presentation of CVT are superior sagittal sinus, transverse sinuses, and sigmoid sinus. But we have to keep in mind that most patients have multiple sinus involved. So more than one sinus is involved in over half the patients. So in our patient, if venous sinus thrombosis is suspected, which sinus is likely thrombosed? What did I just say? More than one sinus is likely involved. So in our patient with lethargy, probably the straight sinus and the deep draining system are probably involved. And what are the imaging studies that will help confirm this diagnosis? And this brings us a discussion of the diagnostic modalities, which are mainly going to be CT and MRI-based studies. So we're going to first start with non-contrast head CT, and we have to look out for dense vessel, cord sign, and venous infarction. So here we have two axial cuts from two different patients. And what can we see here? We have hyperdensity of the transverse sinuses on both images, and this is the cord sign. So the cord sign may persist for up to 2 weeks, and after that, the thrombosinuses become isodense to the brain parenchyma. So here we have a coronal sign, and what do we have here? We have two cord signs, one in the superior sagittal sinus, and here other one in the right transverse sinus. So the specificity of the cord sign is really good. It's over 90%, but the sensitivity is not that great. About like 2/3 of the patients are going to present with the cord sign. So if the cord sign is present, it's really good. It tells us a lot, but if it's absent, it doesn't really mean much. You can't discard CVT based on the absence of the sign. Here we have another image, and we have again the hyperdensity of the superior sagittal sinus, which is the cord sign. We have a venous infarction, and these hyperdensities in the sulci representing a subarachnoid hemorrhage. The subarachnoid hemorrhage and the venous infarctions are more common than the cord sign. So how good is a non-contrast CT for the diagnosis of CVT? So let's say that we have 100 patients with CVT. The direct and indirect signs of CVT can be present in just about half of these patients. So if we assume that the sensitivity is about 40%, then we might miss the diagnosis in about 60% of these patients. So we can't be fooled by a full sense of security if we're examining a patient and they have a negative non-contrast CT, because we might miss a lot. So the specificity of the signs that we talked about are really good. So for example, if you have a cord sign that's very specific, you can go ahead with your diagnosis. But how can we increase the sensitivity of the non-contrast CT? We add contrast, and this is the CT venogram. So here we have an example. We have a sagittal cut of a CT venogram with contrast, and we're seeing here highlighted some of the sinuses. So what is missing from this image? Here, we're missing the interior part of the superior sagittal sinus. So the non-ossification of the superior sagittal sinus in this CT venogram suggests thrombosis. And here we have the same finding, but in a more superior cut. And here again, we have another cut. This is a coronal cut. So it's really helpful to look at different angles. Just as in a chest X-ray, you would never look at just one angle. You're supposed to look at least an additional angle to do your diagnosis. This is another example, and we have here also non-ossification of the superior sagittal sinus. So in this image, what are we looking at? Here is a zoom, And this is a non-ossification of the confluence of sinuses, which is also known as the delta, empty delta sign. The empty delta sign, it's not very common. It's only present in about 1/3 of the patients. And this sign is thought to be, so it's kind of like this hypodense area is the thrombus that is not being highlighted by the contrast. So how does adding the CT venogram help? And here I mean, how does adding the CT venogram to a non-contrast CT? So it boosts the sensitivity to over 80%. So it actually helps out a lot. The specificity of the CVT alone, without the non-contrast CT, it's not very good. It's less than 50%. And that is because the CVT has a tough time distinguishing the thrombosis from anatomical variants like atretic or hypoplastic sinuses, congenital symmetry, and arachnoid granulations. Another imaging study that we can do is the brain MRI or MI venography. And we know that MRIs are good because they're very good at looking at the anatomy and also the evolution of the blood throughout the time. So here we have a MR venography of gadolinium that isolates the sinuses and cortical veins. And this patient is looking away from you. So this is the right side, this is the left side. And I think it's very easy to see what is missing here. So we're missing the transverse and sigmoid sinuses and the vein. Here is another view. And here we're missing the straight sinus and the deep draining veins. And in this one, we're missing the anterior part of the superior sagittal sinus. So the interpretation of the MRV is also susceptible to anatomic variance. But what really gives the MRV the superior sensitivity and specificity is a concurrent brain MRI, because what I said, we can look at the anatomy and the evolution of the blood throughout the time. So when we compare the two imaging modalities, we have CT and CT venogram on one side, and MRI and MR venography at the other side. So the CT, we know it's a very fast exam, so it's done in acute cases. The patient comes in, the first thing you're going to do is a head CT. The images come really fast at the same time that you do the exam, the images are ready. But we have poor visualization of the brain parenchyma and the thrombus. And also another con is the radiation and the contrast. While the MRI is slower, but it's potentially more accurate and safer, but we also have motion artifacts and contraindications, like if the patient has a metal implant. We can also use the D-dimer to help in diagnosis. So how do we use a D-dimer? It has a good sensitivity and specificity, but it really shines in the negative predictive value. It has a 99% negative predictive value, which means that if you have a normal value of D-dimer, so if it is under 210, you're basically discarding the diagnosis. You're ruling out the diagnosis of CVT, right? But what we really have to be careful is that in isolated headache or in patients that have a prolonged duration of the symptoms, like over 1 week, these patients are associated with a false negative D-dimer level. So we never use the D-dimer alone to make or break a diagnosis of CVT because we have so many good imaging studies that we use those instead. I mean, we also use D-dimer, but never isolate it. So our patient has thrombosis of the straight sinus and deep draining veins. She has no evidence of venous infarction, and her D-dimer was 510. So what is the next best step in the management of this patient? So here we come to treatment. So we can use anticoagulation, thrombolysis, and thrombectomy. So once the diagnosis is done, our main priority is going to be to prevent secondary injuries. So we're going to start anticoagulant treatment. And in some cases, when the patient has the right criteria, we can do endovascular thrombectomy. In other patients, we can also treat the symptoms. So if the patient has seizures or intracranial hypertension, we're going to treat that. And in very rare cases, we might have to use decompressive craniectomy. And after the acute phase is gone, we have to try to prevent recurrence. So we have to identify and manage the risk factors for CVT. So 85% of patients will have at least one risk factor, and those can be inherited or acquired. Inherited would be those disorders related to increased prothrombotic states, so factor V latent, protein C and S deficiency, or antithrombin deficiency. The acquired risk factors could be use of oral contraceptive pill with estrogen, or even pregnancy or postpartum. And all the risk factors can be antiphospholipid syndrome, infection, neoplasm, dehydration, chronic inflammation, bowel disease, which is anemia has also been thought to be a risk factor, and head trauma when it involves the sinuses. So for treatment, we're going to use low molecular weight heparin as the first line treatment, and it can be divided in 2 doses per 24 hours. And some patients might need long-term treatment, and that's done with warfarin for 3 to 12 months, depending on each case. And if the patient has 2 or more episodes, they might need lifelong anticoagulation to prevent the recurrence of CVTs. We also have the direct oral anticoagulants, but there still needs to be more studies to validate the safety and efficacy for optimal treatment regimes. And that's it.
Okay. Where are we? There we go.